Good afternoon, everyone. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At the moment, all participants are in a listen-only mode. For those that are connected by telephone and require operator assistance during the call, please press *0. For those online that require assistance, please use the chat box on your screen. I would like to now hand the meeting over to your host, Tanya McDonald, Director, Innovations and Strategic Development at Healthcare Excellence Canada. Please go ahead.
So thank you and welcome everyone to our 8th webinar in our webinar series, Next Steps in COVID-19 Response in Long-Term Care and Retirement Homes. My name is Tanya McDonald and I will be your host for today. I'd like to take this time to mention that I will be moderating today's session from my home office located in Ottawa, Ontario, which is located on the unceded territory of the Anishinaabe-Algonquin Nation. I'm extremely grateful to be able to be speaking to you from this land and recognize the long-standing presence of the Anishinaabe-Algonquin Nation on this land. So before we dive into the conversation today, I'd like to also take this opportunity to introduce our new organization name, Healthcare Excellence Canada. So we are now formed by the newly amalgamated organizations of the Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement. So we're extremely happy and proud to share our new organization name with all of you today. And just to remind people that we will continue our relentless focus on improving healthcare with and for everyone in Canada. And we remain a not-for-profit charity funded by Health Canada. And so as many of you know, this Long-Term Care Plus program is founded on a report that we published in July 2019 entitled Reimagining Care for Older Adults, Next Steps in COVID-19 Response in Long-Term Care and Retirement Homes. The report focuses on 6 key areas that have the potential for organizations to help mitigate the effects of the pandemic as well as respond to outbreaks. The 6 key theme areas addressed in the report are preparation, prevention, people in the workforce, pandemic response and surge capacity, planning for COVID-19 and non-COVID care, and presence of family. As I mentioned, this program was launched in the summer of 2020, and our goal was to support long-term care and retirement homes strengthen their pandemic response in anticipation of subsequent waves of COVID-19 based on the lessons that we had learned back in March and June 2020. And it has been our privilege to support so many homes from across the country strengthen their pandemic response along with us. I'd also like to thank our many program partners who have collectively contributed in one way or another to this program. So the New Brunswick Association of Nursing Homes, the BC Patient Safety Quality Council, CADIF, CMA Foundation, and Manitoba Institute for Patient Safety. So it is my pleasure today to introduce our speakers for today. Jennifer Zelmer, who is current President and CEO of Healthcare Excellence Canada, former President and CEO of the amalgamated organization that brought together Canadian Patient Safety Institute and Canadian Foundation for Healthcare Improvement, and of course former President and CEO of Canadian Foundation for Healthcare Improvement, as well as Andre Picard, who many of you know is a health reporter and columnist with the Globe and Mail. So Andre Picard is a health reporter and columnist with the Globe and Mail, where he has been staff writer since 1987. He is the author of 5 best-selling books. Andre is an 8-time nominee for the National Newspaper Award, Canada's Top Journalism Prize, and past winner of a prestigious Michener Award for Meritorious Public Service Journalism. He was named Canada's first public health hero by the Canadian Public Health Association and a champion of mental health by the Canadian Alliance on Mental Illness and Mental Health, and received the Queen Elizabeth II Diamond Jubilee Medal for his dedication to improving healthcare. Andre is a graduate of the University of Ottawa and Carleton University and has received honorary doctorates from 6 universities, including UBC and University of Toronto. He has recently published his book entitled Neglected No More, an important read about the past, the present, and the future of elder care in this country. So with no further ado, I will pass over the floor to Andre Picard.
Thank you, Tanya. I can see you on video, but I don't think you can see me yet. I'm having some technical problems, but at least I can see you, and that's probably better. the audience not see me. So I want to thank you again for the invitation to join you today in these odd circumstances. You have my voice and my photo, but I am here live. And thank you for this opportunity to discuss some things in my book, Neglected No More, and elder care more broadly. I'm going to speak briefly, and I'm going to speak even more briefly now that I'm not in video. And then I'm going to turn it over to Jennifer to ask some questions and to forward your questions to me. But I want to use a short introductory time to speak briefly a bit about an overview of the book, and more importantly, some of my philosophy on how to improve care for elders in the post-COVID world. So really on topic for what you guys are really digging into. But of course, I will spend most of my time answering questions, and I look forward to those. So this week alone, I saw 2 polls. One said that 90% of people never wanted to go into long-term care, and the other said it was only 85%. Now, these numbers are not very flattering for the sector, and they're also no surprise, especially given the carnage that's occurred during COVID-19 and all the attention that's been focused on the deaths of elders in these facilities. Of the over 22,000 pandemic deaths now, 22,302 at the last time I looked, about 16,000 of those have occurred in these institutional settings, mostly long-term care homes and retirement homes. A very large number, covering around 80%. Then, of course, there was the collateral damage. The loneliness, the isolation, the deconditioning, and the decline that occurred to residents because family givers, caregivers, and friends were locked out. Now that impact was also devastating, but it's all more difficult to calculate. We don't have numbers on that. We just have anecdote. And of course, you know, one of the reasons these numbers are not surprising is nobody wants to lose their autonomy. No one wants to be at that stage in their life where they're declining and they need help 24/7, where they are dispatched to some institution. It doesn't feel good even when it's necessary. So this sector was never going to win a popularity contest. You're not going to compete with Disney World, but it's not to mean it's not necessary. But the book I've written is not about that. It's not about COVID, except very peripherally, nor is it a condemnation of the sector. It's about the larger themes that I've been writing about for many decades now. How to ensure that every Canadian gets the right care in the right place at the right time. That's essential, and it's doubly important for older people who make up the majority of care recipients in Canada. How do we structure our health and welfare system so that everyone can live up to their full potential? That's an important question, politically and socially. And third, how do we, in all our healthcare interactions, prioritize quality of life, not just quantity of life, but quality? So I believe when it comes to elders, especially frail elders, we fail on all those counts, unfortunately, and we do it repeatedly. The generation that gave us our beloved Medicare system and our somewhat less loved social welfare system or social safety net has largely been forsaken by these institutions. Now, this isn't news. There have been at least 150 government-sponsored reports written about the shortcomings of Medicare and how to fix them. And all of them talk extensively about elder care and long-term care in particular and home care. All these reports have the same conclusion. They say that the neglect of elders is a systemic problem. So my view on this, and I state this right in the first page of the book, is if that's the case, well, let's fix the damn system. That's what we have to do now, and we have to do it with more urgency given what happened during COVID. So that's the blunt message. Stop talking about it, stop pointing fingers, stop passing the buck, just fix it once and for all. Assuming the horrors we witnessed during the pandemic finally give us the impetus and backbone to do so, where do we start? That's the other important part of the conversation. I think we have to start with a fundamental change of attitude, with a change of philosophy, if you will. If we value elders and we want them to remain active members of the community, that should be our starting point. And I think we all do value our parents and our grandparents and people who have come before us and created our society. I think we really do, but we have to give life to our beliefs. And once you have that philosophy, that goal, I think everything else is relatively easy. It just becomes about technical implementation. And there are no barriers there. We can do everything that needs to be done and then some. There are about 400,000 elders living in institutional care in Canada. That's one of the highest rates in the world. I think this kind of elder apartheid is unacceptable. It has to end. It can't be the default position to just send people away when they get a little old and rickety. The default setting should be that people stay in the community until it's absolutely impossible. They stay in their homes as long as possible, that they get care, that the communities around them change, and that institutional settings become the last resort. Now, practically, what does that mean? It means shifting some of our spending from long-term care to home care. It also means investing in affordable housing for elders, in community supports, everything from public transit to Meals on Wheels. Now, I'm not suggesting in any way we don't need care homes or congregate settings. Of course we do. I've had, I've lived this with my parents who declined with dementia over long periods of time. They couldn't live safely at home or in the community, certainly not the way our communities are created now. Those places are necessary. But as I said, they have to be a last resort, and they have to be built purposefully. As you know, the majority of residents of long-term care homes, like my parents, are living with dementia. But very few facilities are designed specifically for their needs. For example, with outdoor spaces to wander safely, and not just outdoor, indoor as well in our weather. Homes should also be, well, they should be home-like. They shouldn't be institutional and prison-like. You all know the history of this sector, that it came out of the penal system, the prison system, not out of the care system. And it still shows in the shape of our institution. 200 and 300 bed room facilities don't cut it, even if they're organized into pods of a few dozen. I noticed recently there's a 600 bed facility being built in Ontario. That's really the wrong way to be going. Care homes should be integrated into the community, and ideally they should be paired with other facilities like daycares and schools. I'm no spring chicken myself now. I'm getting up there. And I recognize that elders should not be invisible in our daily lives. We also have to stop pretending that old people only want to spend time with other old people. It's not true. They want to be stimulated. They want to talk to younger people. They want to see kids playing in the park, just like all of us. They want to be part of society. We can't shunt them off continually. So I'm happy to talk about the nitty-gritty of how to make these changes during the question period. But I just want to touch on a couple of little other big issues before I turn it over to Jennifer. Now, the question I get asked most often when I've been talking about this and talking about the book specifically is, where do we start? It can be overwhelming. There's so much to be done when you look at this sector. Where do we start? I think, well, once we have that change of philosophy, and I think we are on the cusp of that, I think we have to start where the biggest problems exist, and that's clearly staffing. Healthcare is a people business, and we need a sufficient number of people to provide care, and we need well-trained people, and we need to recruit them, and we need to retain them. There can't be this constant churning of people in and out and no stability. So people are really where it starts. There's been a lot of clamoring lately for standards of care. There's been some big promises that they'll be implemented. So, for example, guaranteeing 4 hours of hands-on care. Good starting point. That goal is really about 25 years old, but, it's a starting point. It's probably not sufficient, but we can do that. We can also start with things like, aside from mandating hours of care, the mix of care. The RNAO in Ontario, Registered Nurses Association, have recommended a ratio of 20% RNs, 25% RPNs, 55% PSWs. I don't know if that's the right mix, but it's an example of the things we should be discussing in some detail and acting on. The number of nurses in nursing homes has been dropping dramatically over the years. In some cases, we can barely call them nursing homes anymore because they have so few nurses. I mentioned infrastructure briefly, and I think that's important too. Where do you start there? I think you start by getting rid of the places where infectious diseases thrive, ward rooms with 3 and 4 beds, which do harken back to the prison system. Until 1961 in Canada, we had facilities with up to 20 beds in a room. That's when we legislated a maximum of 4. But we should have legislated 2 back then, and we should do it now. But that, of course, will take time. Eliminating ward rooms takes 5,000 beds out of the mix overnight. So we have to, and we have a waiting list of 34,000 in Ontario alone. So these are not easy questions to resolve. Now, money is always a big question. Do we need more? You know, do we have enough? Is this affordable? I think absolutely we need more money. And why? Because we've neglected this sector for decades. So there's some serious catching up to do. I don't think it's an unreasonable amount of money. We've spent almost $400 billion on pandemic relief. What's another 3, 4, 5 billion for elder care? It's nothing in the grand scheme of things, and it's a good investment. It's good investment in an aging society. We also already spend a lot of money on care, on elder care, long-term care, and home care. Gobble up a lot of money, but we don't spend it well. We don't get value for money, so we have to pay attention to that value proposition. Again, an important issue in this group. The final thing I'll say by way of introduction is that this organization is about excellence. It's about innovation. And these are really the key to reforming healthcare generally and to elder care specifically. So you're well placed to tackle this issue, and I'm glad you're doing it in this format. During the pandemic, patient-centered care has taken it on the neck. I think, you know, we've seen all the movement towards patient-centered care step back by years, maybe decades, and we have to recapture that. We have to get the patient and consumer voice back into the mix, and we have to do it quickly before it's completely eroded. And it's, again, especially important in this sector where many people can't advocate for themselves. People with dementia and other conditions can't always be active participants. And of course, people need choice. I know choice is often a dirty word in Canadian healthcare, but we need choice about where we live out our final years. We don't just need care, we need quality care and dignified care, and we should get it where we want it, wherever possible. And that's usually at home, not in a congregate setting. Once you put the emphasis on quality, everything else seems to work itself out. It falls into place. Quality care, then you automatically have to deal with standards. You have to deal with safety, with infection control. That's all about quality. So finally, a few words about innovation. As you can tell from my brief comments, my book is a sometimes harsh condemnation of the care we provide to elders. And I think that harshness is justified. But I think it's ultimately a hopeful book. It's hopeful because I stress that not only do we know all the problems, 150 studies worth over 50 years, we know every problem inside out, but we also know what needs to be fixed. And most importantly, we know the solutions. Elder care, like health care, has to be provided on a spectrum. Yes, is provided on a spectrum, I'm sorry. There are some terrible homes out there, and I won't hide that, but there are a lot of good ones too. And I should note, there's way too many mediocre ones. I think that's the most unfortunate of all. But every problem we have, every problem I've talked about has been resolved. It's been resolved over and over again in these good homes. And we have to scale up our successes and not see this as unfixable or something we just have to live with. So again, I want to leave you with that hopeful message. Everything's fixable, everything's doable. Learn from what you're doing right. So I think I'll stop there. Jennifer, if you want to take it away and ask questions and bring in the audience, and I will be here as the invisible voice of God from afar.
Thanks so much, Andre. I actually got a message from our tech support folks that you might be able to turn on your camera now. So if you want to give that a try. While you're doing that, I will say I'm joining this call today from Lake Tanya, from the Ottawa area, the traditional unceded territory of the Algonquin Anishinaabe. And I'm so fortunate to live, work, and play in this space. as to connect with all of you across the country. So glad to see people introducing themselves in the chat who are living, working, and playing on lands that have been walked by Indigenous peoples since the beginning. And in doing that, I will invite you, for those of you who haven't introduced yourself in the chat yet, feel free to do so so that everybody knows who's on the line. And as you have questions or comments or thoughts for Audrey, please do type them in there as well. Ah, success, we have pictures. It moves. So we've got that opportunity for looking at some different kinds of discussions and questions. Audrey, I know you've been talking with lots of people about your book, but hopefully we'll have a really rich additional conversation today with lots of folks who live, work, and play in this space and have an opportunity to continue that conversation. But maybe I can start us off now that we're actually able to see each other on video with just sort of following up from your comments. You started by talking about the fact that we've identified systemic problems for years, and that one of the challenges that we have when quality improvement teaches us that every system is perfectly designed to get the results that it gets. So can you talk a little bit about the shift in values you spoke about and how you see that happening, as well as some of the more concrete actions that you mentioned?
Yeah, it's a very good point. And I want to thank the IT people who were working furiously behind the scenes. I was trying to multitask there, trying to figure out how to turn on my camera, but I figured that out afterwards. So, yeah, I think the values question is really important. To me, that's what this is all about. It's about giving life to our values. And I don't think we always do that in Medicare. I think we did that in the 1950s. We had this situation where people couldn't afford care, and we decided to fix that. And we created a system for it. But that system just hasn't been updated or flexible. We created a wonderful system for the 1950s. It's all about acute care, making sure that people can afford their physician and hospital care. But we have to extend that to other, what is now essential care, getting long-term care, getting home care, drugs. All these things have become more essential over the years, and we just haven't been able to adapt largely in the Medicare system. I don't think it's a values problem. I think it's a technical problem of giving life to our values. And we tend to just get caught up in things like legislation, like we're obsessed with the Canada Health Act, what's in there and how does it read. And it's important, but I think we give it way too much importance. We should be talking about what it does rather than what it says. So I think a lot of these things are solvable, but we have a lot of we're very small C conservative in Canada. We don't like to change things. We're reluctant to do anything about something like the Canada Health Act because we're afraid it will be a Pandora's box, and I think that is a risk. And if we do fear that politically, I think the way to do it is create a parallel program. There's no reason we can't have a separate funding envelope for long-term care homes or home care or both of them put together. There's no reason we can't have, like a country like Germany, have long-term care insurance in addition to our acute care insurance. So all these things, again, are solvable. So I think that's the good news. And I think we do have the right values in Canada. I think we do want to care for people. I think it's exemplified with our elders. I have a chapter in the book about Sunnybrook Veterans Center. I think the care there is superb. And there's no reason what we do for 475 veterans we can't do in every care home across the country. So again, solution is there. Let's just get to it.
And maybe picking up on that, the first question that was asked in the chat comes from John Knock, and he was asking about Eden Alternatives and other approaches to resident-directed care, which I know there's some elements of that at Sunnybrook and some of the other places that you spoke about. I wonder if you can talk a little bit more about what you've seen on that front and what your thoughts might be.
I think there's many of these models, and I don't get into them too much in the book. I think most of them are sort of have different names for I don't know, I guess capitalist reasons, so they can sell their program, et cetera. But essentially, they all do the same thing, right? They all say person first. It's not about, we have a very task-oriented system, and that's we fund tasks. So that's what we get. It's not the fault of the workers. That's how they're paid to work. So what these homes do, and people pay a lot of money out of pocket for this, is do what's sensible. They say, what does the person, what are their wants, what are their needs? So take a place like Sunnybrook, which is publicly funded, and they say, well, you know, you are living with dementia, average age is 96, so you don't have long to live. How can we ensure you have the best quality of life for the time you have left? So that's their pretty simple philosophy. And then it's very different from other homes. It's like you eat when you want, you get up when you want to go play in the garden, you do that, you want to wander. You know, a lot of them have dementia. I tell a great anecdote in the book about one of the veterans being out in the garden, and he starts pulling up all the flowers. And the gardener gets angry. And he yells, oh, you've got to, he says to the nurse who's accompanying him, you have to stop him from pulling up the flowers. You know, I've worked all morning to do this. And she said, no, I don't. It's his garden. So it's about ownership, you know, feeling a sense of belonging, not just being a tenant, but being the owner of the space and of the care. So I think that's all these things, Eden, whatever, Dementia Village, that's what they're all about. They're all about saying, let's figure out what works best for the person, not try and fit them, not try to fit these square pegs into round holes all the time, which I think we generally do too often. And there's a whole book that looks about all these models around the world. Moira Welsh at the Toronto Star has just published this book, so I'll give a shout out to my competition. Another great book, which I think is very complementary to what I write about, because it gets into those details.
Which is maybe actually a good segue to our next couple of questions which were related. And maybe I'll approach it this way, which is a slightly different way actually than the folks in the chat approached it. So my parents live in Australia, and Australia has just published a new report, a new commission report on long-term care. And I was talking to my dad over the weekend, and he said, yeah, and the news has already moved on. So how do we make sure, you mentioned the number of reports that have been published in Canada, there have been many. How do we make sure that the spotlight stays on this issue for long enough that we can make the significant improvements in care for older adults with and for them, rather than moving on to the next issue?
Yeah, it is a big problem. We have short memories. We do move on. I think the worst thing we can do is just do, you know, Australia did these reports, and they're great reports. I've read them because it's always spurred by a crisis, right? So they had all these stories about neglect and people dying in horrible circumstances, all pre-COVID. So they tackled this. Now, we do this too. Whenever there's a crisis, we're going to have, I don't know how many studies of COVID, but I think we have to, I think the fundamental key, the fundamental thing for me is start doing reports differently. So I don't want just reports that hash over what went wrong and recommendations that we never follow. So I want inquiries that are very specific. I'll give you an example. So if I was in Ontario, I'd say, resolve this standards of care issue. Tell me exactly how many hours of care we need to provide and how much it costs. And the most important thing I think about reports is we should commit upfront to implement every recommendation. So none of this cherry-picking business where inquiries essentially just become doorstops. We pick out a couple of easy, low-hanging fruits, and then we move on. So you have to commit upfront. And I think to be realistic, you can't be open-ended in politics. I would say, you know, I want to resolve this standard of care problem, and I have $1 billion. Tell me what I can do to fix this and not spend more than $1 billion. So I think you have to give really specific parameters for studies rather than these open-ended things that end up being open-ended nothing. So I think that's how we don't necessarily have to keep it in the news, but you have to keep it on the policy agenda. And the way to do that is to have specific commitments. So I noted yesterday, Manitoba published, there was a care home disaster there, the Maple home, where there was a large number of deaths, and they called an inquiry, but into a specific home. And yesterday I was really happy to see the government said, we are implementing every recommendation, and we've appointed a team to put a timetable and a cost on. That's the way you do it. So kudos to them. Now that's one home, you know, out of a big system, but there's no reason you can't scale that up and do that everywhere.
Well, I love your concept too around, you know, a focused set of questions. You know, there's good research in the innovation space that actually by providing a box, you can then get even more innovation within that space rather than just leaving a blank sheet of paper wide open. So it's an interesting sort of application of that here. A couple of questions have come up around not only how do we keep the policy focused, but how do we also make this an attractive environment for people to work in? So whether that's in long-term care in retirement homes or in the community providing care for elders, how do we make this a career of choice?
Yeah, I think it, in the book I quote the legendary Pat Armstrong, who says, the conditions of work are the conditions of care. So if we want our elders well cared for, the workers have to have a good environment. You cannot provide good care when you have a crappy work environment. Those things go together. So how do you make it attractive? Well, you ensure that people have jobs that are fulfilling, that pay a decent wage. The pay is important, but and I talk to a lot of workers in doing my research, and the pay isn't the number one thing. The biggest frustration I heard from PSWs, from nurses is, I don't have the time to care properly. I go home feeling guilty. I don't feel good about myself because I know people are not getting the basics. So I think you have to have more, freedom for the workers to do what they know needs to be done. It's very regimented, a widget-like system. You have to do X number of things in this quarter hour. And that's again, is not the way to provide good care. When we talk about these Eden homes, dementia villages, they're about that. It's like, I adjust. You don't want to eat lunch now, you want to go for a walk, let's do it. I don't care what time lunch is. So that rigidity is a bad thing. Of course, benefits, paid sick days, all these things make working easier. Full-time work, these PSWs who have to work in 3 or 4 homes to make ends meet, none of that makes for good quality care. In Ontario, when you have this constant turnover of home care agencies, no continuity in care, people hate that. You have a different home care worker every week. That doesn't feel good in your home. You want to see the same person. My mother lived in a small town in Northern Ontario. She had home care for many years, and she thankfully had the same person, but that person kept getting moved around agencies and getting her pay cut. We ended up we supplemented her pay just so we could hang on to her so she wouldn't leave her job. That's not how things should work.
And, I think a number of comments in the chat on exactly that point about, is it a task orientation or is it a quality and resident-centered orientation? And how can we make sure that it really does reflect the evolving needs as well, right? Those are not static needs. I'm sure your mom's needs weren't static. Neither are those for most people.
Yeah, and I think that's one of the hard things is we have to ensure this continuity of care. So we have good, mediocre primary care in Canada. We have good hospital care, but then you really fall off the cliff, right? When you get out of that little Medicare basket, you can really fall off the cliff, and you only get really good care if you're wealthy. So the government provides the very basic, and then you supplement it. We'll probably get into the private-public question because I know that's a big one. But
it was indeed in the chat, so feel free on that.
Yeah. But it's not a black and white thing. A lot of people in public homes buy private care to supplement because they don't get enough. So there's a real mix there. I forgot where the question was, where I was going with that. But we could talk more about private later if you like.
Well, we may as well transition to that now because it was indeed in the chat. So, feel free. The question was really around, some of those dilemmas, right? We've got a mix of public and private ownership. We've got a mix of public and private payments. I think the question was around what's your view on that mix and where we should be going?
Yeah, I think the main thing is we have to be careful. I think it's simplistic to say we have to just nationalize all homes, get rid of all private care. I think that's a simplistic solution. I don't think it would make care better overnight. Now, that being said, I don't think we need for-profit care. It's not essential. Right? I wouldn't lose any sleep if we were like Norway and we had only public homes, right? But I think we have to understand, why is it there? Why are there so many for-profit operators, almost 60% in Ontario, for example? Well, it's because governments won't invest in infrastructure. So you have to resolve the problems that brought for-profit care, not just demonize it. I think we have to recognize, too, that all homes, private and public, get the same government allocation. They get the exact same amount, about $180 a day per person. They don't magically get more because they're private. They make their money elsewhere. I think the people we need to get out of long-term care are not all the for-profit operators. A lot of them are little families who make a little profit off these homes like they would off a corner store. And a lot of those homes are decent. I think the people we have to get out are the, how can I put this politely, sort of the parasitic capitalists, you know, the hedge funds, the people who are just slum landlords. There's way too many slum landlords in our long-term care facilities. They don't really care who lives there. The care is secondary. It's not important. It's about making money off buying and selling land, about renting rooms at an exorbitant rate. So I think we have to make that distinction. I'm all for getting rid of them, but just saying no for-profit seems very simplistic. And the final thing I'll say about that is I don't know anyone who thinks that more government will solve these problems. So I think we have to be cautious that just making something public is not going to make it magically better.
You may have given me a perfect segue to another one of the questions that came up in the chat, Andre, because the question was really around, so where's the leadership going to come from in our decentralized system? And there was also a question around from someone else around how do you get involved in advocacy for better care? Maybe you can blend those two things together.
Yeah, so I think I hesitate to use the word system because it's not. There's no organization, you know, there's these informal groupings of homes, but even finding out exactly how many homes there are in Canada is not a given, right? They're all scattered. We saw that in the COVID response. It was hard to respond because we don't know who runs what, where and why, and how many people are there, except roughly. So some of the basic structural stuff, there needs to be better oversight at the large oversight from government. How do you advocate? I think it has to be like everything else in healthcare. I think that the patient voice, the family voice has to be a lot louder. Canada, when I compare us to other countries, I'm always struck at how we have these powerful organizations of doctors and nurses. We don't really have a powerful patient organization. You know, if I look at France, you know, the patient society in France is as powerful as the doctor society, right? And we don't have that here, and it's an odd thing, especially given that we have a very public system. I think the patient voice has to get organized. It has to be less fragmented. We have, I think, advocacy by disease and by body part in Canada. We don't have much advocacy for whole people, and that's unfortunate. So I think we have to fix that, and governments have to fund that. They have to fund these groups to keep them to account. We need things like seniors advocates. BC has a superb advocate for seniors, Isabel McKenzie, who I think has done as much to improve elder care as anybody in the country. So we need that kind of ombudsperson specifically for this community. So there's all kinds of ways we can do advocacy. I think during COVID we've seen a remarkable upsurge in advocacy on places like Twitter from all kinds of people, like people who are not in the sector, you know, pharmacists and teachers and all these kinds of these people who are peripherally involved in the system because they have loved ones or whatever. And hopefully that momentum will continue afterwards.
That's great. So I think there's a couple of questions that I'm going to transition a little bit to a different topic. But in the meantime, Audrey, here's your chance to plug your book again, because two separate people said, what's the title of that book again, and how can I get it?
Yeah, so the book is called Neglected No More. Available in fine bookstores everywhere, and even not fine bookstores, I think. And if you can Google it online, in the weekend, there was a review in the Globe about it. I'll put it in the chat, see if I can multitask on that.
There we go.
And somebody was asking about the name of Moira's book, and I'll find that because I have it kicking around my mess on my desk somewhere.
It's handy to be in a place where you can just grab things and bring them forward. And thanks, Maria, for putting the link in the chat as well. So a couple of questions have come up in the chat, Andre, about models for community-based living. And I know you've mentioned several in your book. People are interested in, can you speak a little bit more about what some of those models might be and how could we help to support them and grow those kind of models?
Yeah, I think there's different levels and of models. So I'll talk about a really simple example is something called NORCs, so naturally occurring retirement communities. So we know demographically that there are neighborhoods where there's a lot of older people, right? So people have been there, they've been in, you can drive around, you see those neighborhoods where people have lived in the same home for 50 years. So what do you do there? Well, instead of shipping them all off one at a time to a home or a retirement community, you start bringing services to them. So this was done in Kingston. There's a group called Oasis that did this really well. Took a couple of apartment buildings where obviously everybody was aging, and they just saw their neighbors leaving one at a time. They said, why don't we bring nurses here? So they started bringing the home care services to there, and it was a way people stay now like 4 or 5 years longer because you bring these simple services to them. I think one of the most interesting things I learned in my research is people go into facilities for the most mundane reasons. They can't shovel their walk anymore. They can't buy groceries. The bus doesn't come too often. They can't walk down the stairs. A lot of these things can be fixed really easily. We can have volunteers bring groceries. You still pay for them, but the volunteer does the shopping. These are really cheaply solvable things that can, and I think we have to make a greater effort to do that, to stop the inflow of people who don't need to be in homes. So that's an example. Another community model I wrote about Toronto Public Housing. So Toronto Public Housing has a number of facilities. They have one in North Toronto, a few apartment buildings. So they did the same thing. They have live-in. They brought the caregivers to live there. So 24/7 care, not the same level as a nursing home, but 24/7, there's always somebody there. And they drop into the apartments. Instead of everybody moving, the care comes to them. And they have flexibility. So because they're there, hi, my job today is what? Oh, give Mr. Smith lunch. So let's go see Mr. Smith. Well, he's not hungry now. Fine, I'll go down the hall and I'll give Mrs. Jones her bath. And I'll come back and do lunch later. That's unthinkable in a home, right? Or in a traditional home care. Traditional home care, you're allocated your hour and you have to do these 3 things whether you want them or not. So it's the care you are given. It's not necessarily the care that you want. So those are just 2 examples of really good community-based care, much cheaper. And just an example, if I come back to that Toronto Public Housing, across the street from them are 2 privately large facilities of just private apartments. Exactly same demographic. They're not allowed to go there. So what happens in those homes? 14 care providers come in and out every day. It's absurd. It costs so much more. You could move one of these people in to take care of the whole building, but they can't do that because different program, different funding, etc. So there's a lot of structural and bureaucratic barriers to doing things we know we should be doing. And I see somebody put a link to the Oasis program. Thank you.
Yeah, and also Cynthia's posted an example from rural Manitoba as well. And I think some of these examples bring up that interesting question around equity, which was also raised in the chat. We've got points of light, right? We've got these great examples in different parts of the country that we can point to that are amazing. Some of them, as Cynthia suggested, are the result of strong community advocacy and fundraising. Others may be the result, as in the examples that you talked about earlier, Andre, of people being able to pay for some additional services out of their own pocket to potentially consolidate that way. I wonder if you can talk a little bit about your thoughts around equity and how do we work towards better with and for everyone, not just for the few?
Yeah, so equity is, really important and not the same thing as equality. So not everyone needs the same amount of care. So we have to ensure people get the care they need. And it is, the long-term care system is very much about you get better care if you have more money. And that's, I don't think that's the Canadian way, or at least that's not how I perceive it. So I think we're always going to have people who have more money, additional care. But I think what we have to do is ensure that the basics are better. So the basics shouldn't be, so what's funded as the basics? It's really just a wardroom with very minimal quality standards. $9 a day for food is what Ontario allocates to people in long-term care. That's sort of what prisoners get, right? It's not, you're not going to get quality nutrition. I think there has to be just more investment there, more to guarantee a lower floor, if you will. I think bringing up the floor is the starting point for equity. And then I think that we have to adjust for, recognize that certain neighborhoods, certain communities, maybe racialized communities, they need additional resources when they're in both in home care and both in long-term care. So there's very much a trend of having homes for people with different languages, for example. We know that when people have dementia, they often revert to their original language. They lose their English, so they'll only speak Chinese or Slovakian or whatever. And that's a great movement. There's a lot of these great homes. And one of the really good things about them is they have really strong support in their communities. So people aren't as isolated. People go in and speak the language. There was a wonderful program, UBC med students during the pandemic who speak, or are from various backgrounds, speak a couple of dozen languages. They started Zooming with people in elder care facilities to speak in their languages, just so they didn't lose that, so they felt that connection. So there's all kinds of little things. What did that cost? It cost nothing, right? So there's so many things we can do to make life better that doesn't involve spending countless amounts of dollars. And that is an important part of equity, is making people feel they belong.
Mm-hmm. And part of that, particularly in the examples that you just talked about, was community mobilization and that sort of community building more broadly in an intergenerational sense as well, with the med school examples that you spoke of.
Yeah, and I think the intergenerational part, I alluded to it in my talks. What I love about the Nordic countries is when they do have homes, again, they're home-like, so they tend to be smaller. But not only are they smaller, but they're integrated into communities. They're often attached to a daycare or a school. And that's important. It's important for young people to see older people. And I think that's another thing I've seen in the pandemic. I've seen this younger generation wake up to what's happening to their grandparents, right? I was doing I'm not a cool kid, but I was invited to one of these Clubhouse Clubhouse is a really popular app for younger people. So where you chat, it's sort of you go in there and chat with people about a specific topic. So I was invited to one, and it was all people in their 20s and 30s talking about long-term care, and really, powerful advocates, and they're outraged by their grandparents' treatment. And I think that, again, that gives me a lot of hope. That generation gets involved, they recognize, and I think we all have to recognize that's where we're going, right? We all are going to need this care eventually. I didn't mention this earlier, but I think we also have to recognize that this aging of the population is actually a really good thing, something we should be celebrating. When I see someone in Clubhouse saying, oh, my grandmother who's 80 and her mother, my great-grandmother who's 101, I Zoomed with them. I said, that's fabulous. Like, a generation ago, was unthinkable of having a 101-year-old great-grandmother and an 80-year-old grandmother and a 40-year-old mother. These things this is magic, right, when we can have these generations living together. So we should be celebrating this stuff, not being depressed about it and shoving them off. So we have to ensure that not only do people live longer, but they live better and more connected.
Mm-hmm. Yeah, I feel so fortunate, actually, that growing up, I did have a 101-year-old great-grandmother, and her sister lived to be 109. So I had wonderful people in my life of many generations, but that's not that common, or wasn't that common. So we're so fortunate that so many other people have that experience now.
Yeah, we don't all have the benefit of good genes. We don't all have good genes, so.
Well, we'll see if that, all translates down. They also had a few other things going on that made them very strong people. So there's been a comment in the chat around, recognizing the nature of relatively average short stays in long-term care. So on average, 18 months before end of life. And I know you spoke about in your book, end of life care in long-term care. And supporting palliative care in long-term care as well, which is something that we focused on too. So I'm wondering if you can talk a little bit more about that.
Yeah, so I think we have to recognize this, right? If people are only going to live on average, it's about 18 months in care, then these essentially should be built as palliative care facilities. They should be about maximizing the quality of life left, right? I don't think it's a bad thing that people don't live long in these homes. I think what's more important is that we treat them as palliative patients. And it's appalling how little palliative care is available in facilities where we know everyone is going to die, right? That's why you go there. That's the last stop. And that shouldn't be a bad thing. Shouldn't be a thing you dread if it's a place that's going to make those last days and months better and even happier. So, you know, I talk in the book about a doctor, a medical director who says that's her philosophy. Our philosophy is this is a big palliative care home. And I don't, you know, I have the pleasure in my work of visiting, or I used to when we were allowed to go outside, of visiting a lot of facilities. And I visited many palliative care homes, and paradoxically, they're happy places. They're very hopeful and happy places. There's weddings, there's birthdays, there's anniversaries. And people die I would think I'd go so far as to say happily. They satisfied, content. And that's what it should be all about, right? That's what long-term care should be. It shouldn't be about dreading sitting in a wheelchair, strapped in, sitting at the elevator, wondering if anyone's ever going to open the door and you can see someone. That's the life for too many people. So it should be about making their lives as pleasant as possible for those remaining days. And again, I point to Sunnybrook. You know, these veterans, a lot of them close to 100, and that's what they do. They have a pub, they have their own pub, they have a library, they have live music 3 times a week at least. They have outings. You know, the 100-year-old guy, and they're almost all guys, get on the bus and they go somewhere. And they go see something, go to Niagara Falls, or what. You ask them what they want and they do it. That's what your final days should be about. They shouldn't be about cowering in fear in your room, wondering why you can't see your loved ones.
Your best day today.
Yeah.
Andre, you talked about hope and the importance of hope and the fact that you wrote this book from hope. Can you talk a little bit about what gives you hope and how you would hope that this book will influence the path forward?
Yeah, I know it's an unusual thing for a journalist, but I am quite hopeful and optimistic about this. And what gives me hope is what I mentioned before, is I think different generations are taking interest in this. I think they're recognizing that. I think what gives me the greatest hope is I know that everything is solvable and that has been solved. So I think, you know, it's so easy to fix this. And I think the final thing is just so much attention has been focused on this because of the pandemic. You know, I think there is a reckoning that has to come, and I hope the reckoning is fixing what was most broke, if I can put it that way. And I think this pandemic exposed many failings and things we don't do quite good enough in society, and nothing was in the spotlight more than long-term care and to a lesser degree retirement homes. I don't think they've got near enough attention. They have their own issues. But I think that combination of those 3 things, the younger people getting involved, the ability to do this relatively easily, and the focus, I think all those things, hopefully will create this a perfect storm of giving us the opportunity, the political opportunity, and the societal desire to act on this finally.
Mm-hmm. And I think in giving that answer, you've also answered one of the other questions that just came up in terms of priorities. So we're running towards the end of our time, Andre, but I wanted to give you a last opportunity. Was there something I haven't asked you that we haven't as a community asked you that we should have?
Oh boy, what have I not talked about? I think we touched on all the big topics, but I think I'd use the time to just reiterate the important one, is that this has to be a continuum, right? We can't just fix something in isolation. As much as I want elder care to be fixed, I don't think we can just do it alone. I say in the book, I think the single worst thing that could happen is we just build more beds, because we don't need more of what people don't want. We don't need more mediocrity. We need to actually do things pretty fundamentally differently. And that means having everything from good primary care, hospital care, long-term care, palliation. It all has to be part of the package. And if we just fix little dribs and drabs of it, we'll never get excellence in our care. So I think, in an organization like yourself, that it's all about excellence. That's what this ultimately is about. The way to get excellence is to focus on quality, to focus on people's needs, to listen to the public. And I think the final thing, I guess the one thing we didn't talk about enough is caregivers. So they're the backbone of all this, right? I talked about paid staff, it's really important, but 80% of all the care is delivered by the spouses, the 88-year-old spouse of the 85-year-old who's doing literally the heavy lifting, working 40, 50 hours a week. Those are the people we have to help out. We've abandoned them, and we've particularly abandoned them during COVID. We've, crushed their spirits by locking them out. The vast majority of people deliver this care lovingly and willingly, and we have to allow them to, give them the means to do it and give them the backup when they need it. So I think that's probably the single most important thing is help the people who are doing all the work or most of the work now, and again, a lot of it will flow from there. It's, stop this reflex of just sending people off to institutions, stop this reflex of working family caregivers until they burn out and they're on the verge of death themselves. Give everybody a breath and a break and listen to people about where they want to live and how they want to live. And I don't think, and the final thing, I don't think, we always say, well, this will cost too much. People will exploit it. They'll take advantage. And I don't think there's any evidence of that whatsoever. I think it's the opposite. I think Canadians are really reluctant to ask for help until they desperately need it, and then it's too late. So I think we have to change this attitude about, yeah, we're going to be there to help you when you need it. Don't be afraid to ask. And we're going to give you the care you want and need, where you need it, and when you need it.
Mm. And to a point that you made in your book, making it easier to find out where that help is and not having to give yourself a migraine navigating it as well.
Yeah.
Andre, on behalf of absolutely everyone on the call today and those who will watch this afterwards, thank you. Thank you for our conversation today. Thank you for writing the book, which is Neglected No More, and the link was in the chat for those of you who wish to follow up. And I'm now going to turn it back to Tanya, who's going to close out our session for today. Thanks so much.
Great. Thank you, Jennifer.
Thank you very much again, Andre Picard and Jennifer Zellmer for leading us through this conversation. We really appreciate both of you taking the time today. So just in terms of following up in terms of next steps, so the Long-Term Care Plus program continues. So our ask is that you continue to learn with us, to learn with each other. We're hearing from you that the opportunities for peer-to-peer learning are just extremely valuable to all of you. So we hope that you continue to learn with us and with each other. We are taking a pause on monthly webinars as we regroup as a team and start looking for more relevant content to share with you throughout the spring and summer and fall months. And so our webinars will be restarting in May, as well as our national huddles. So we look forward to reconnecting with all of you in the coming months. And also there may be some other opportunities that are present itself, so please stay tuned. We also just like to celebrate again the community that we have become as part of the Long-Term Care Plus program, with over 1,000 teams working with us from across the country to strengthen their pandemic response. And actually beyond that as well, I think as the months have gone on, we have seen a shift in priorities towards the people in the workforce, towards that continuity of care. And I think that Andre and Jennifer touched on that, the quality of care that is given and those continued healthcare needs as we move forward, and as well the presence of family, which has continued to remain a priority for all of you throughout the pandemic. And so we look forward to continuing on this improvement journey with all of you. We are so grateful to be able to support you through this work and to provide you some relevant content and those learning opportunities. And then so finally, you can mark your calendars for our final huddle in the webinars in this series. We will be featuring Nadia Fortier from the Centre Intégré de Services de Santé de Services Sociaux de Chaudière-Appalaches, so a health region in Quebec, where they will be presenting on the implementation of a non-pharmacological approach to address negative expressions and wandering in clients with major neurocognitive disorders. So they will be leading the huddle discussion at 2 p.m. on March 18th. So thank you. So just a great thank you for everyone who participated today. Thank you to Jennifer Zelmer and Andre Picard for this conversation. And we look forward to engaging with you again in May. So thank you very much.
This concludes today's webinar. Thank you, everyone. You may now disconnect.